Feeling trapped by outdated cancer treatments? You're not alone. Welcome to Off-ScriptRX, where we break free from the limits of conventional medicine and open the door to revolutionary repurposed medications. I'm Dr. Nathan Goodyear, and this podcast is about disrupting the cancer care status quo. It's time to reclaim your health with treatments they don't want you to know about. If you're ready for a future of real possibilities, you're in the right place. Rethink repurposed medications. Rethink reality. All right, welcome to another Off-ScriptRX podcast where we are just two doctors talking repurposed drugs and doing a little repurposed drugs, I think, especially this time of year, a little hoarse voice, we're doing a little repurposed drugs to keep ourselves healthy and well through this holiday season. I hope you're doing well this holiday season, Christmas season upcoming, and New Year's 2024, now 2025. Joe, always good to have you on the podcast. And there's been this topic that you've been talking to me about a long time. And I just figured it was a pharmacist complaining and, interesting to listen to. But I don't really know all the business angles and the strains. And I know there's been, as an independent pharmacy, which understand the United States is built on independent businesses. But as an independent pharmacy, I respect and care for what you provide. And I know you provide a great service for the people there in Lenore City. But I heard President-elect Trump mention in a speech earlier this week something that you've talked a lot about, PBMs. And a lot of people are going to go, what the heck is that? But PBMs, really are something. I'll let you take over in just a second. But it wasn't just that he said that, but it was that Robert F. Kennedy, the hopefully to be approved Health and Human Services nominee, and then Dr. Oz, the Center for Medicare and Medicaid Services nominee, they also voiced that same opinion. So, Joe, what is a pharmacy benefit manager, also known as PBM? And I want to hear this first from a pharmacy perspective, but I want to then step back and say, what's the impact on patients? What's the impact on doctors? What's the impact on access to care?
I had to think a lot about this. It's like, how do I explain this without cussing? So I
have a bleep button.
Yeah, get ready. No, okay. So PBM is the acronym for Pharmacy Benefit Manager. If there is a definition that needs to explain to anybody what. Hang on a second. I've got my computer's gone off kilter here.
PBM's already hacking you, man.
Yeah, they know I'm talking. If you can see me, I can't see you for the moment.
Okay, I'm here.
Okay, so anyway, I'll keep talking. So PBM, if you want to point at something and say, what is a middleman, then the PBM is the ultimate middleman. They have wedged themselves within the healthcare system, in between the insurance payers, insurance such as Blue Cross, that might pay, if you had a Blue Cross Blue Shield card that would pay for some medical service. They put themselves in between them and us, the pharmacies that dispense medicine. They're also, have their hand in a whole bunch of other things too. But for today's purpose, we're going to talk specifically about the pharmacy benefit management side of it, which is simply, I'll give you an example, a true example. I got a call from Blue Cross Blue Shield, and they said, how come you're not going to fill this prescription for, patient X? And I said, well, how much did you pay me? And they said, well, I can't tell you how much we paid you. And I said, well, it should be on your computer. And they said, well, from Blue Cross Blue Shield's standpoint, they said, clearly, we have allocated $300 for, drug X. And I said, well, I would gladly take $300 for drug X. I said, but you only paid me $121. and it cost me $171. So that's an example of what happens to us. I need to make money to pay for my drugs. I got to pay my staff. I got to pay insurance bills, et cetera, et cetera.
And you got to put some weight on Skelly back there. Yeah.
What?
You got to put some weight on Skelly too back there. You got to feed Skelly.
Yeah. Hang on a second. I'm trying to figure out where you went on my screen. But anyway,
Well, I see you just fine, Joe.
You see me fine? Okay.
Yeah.
Anyway, so so when I was talking to him, I said, retail is quite simple. You must buy low and sell high. As long as you do that, you're going to stay in business. It's a simple concept. However, the PBMs don't see it that way. And what's interesting about this particular transaction I'm discussing, it involved a company called Express Scripts. They're a PBM. They were hired by Blue Cross Blue Shield to manage, and I use a quote unquote manage because it's really just a legalized method of stealing. But they give all this pomp and circumstance to the insurance guys and says, "Oh, we're going to improve compliance, and we're going to save money, and we're going to reduce all this waste, and it's better for Blue Cross Blue Shield to contract with the PBM in order to save all this money." Well, the PBMs, they keep what they call the spread. So the $300 before it gets to me goes through Express Scripts, as this example, and then they take the difference between 300 and 121 and send it to me. And so they keep that difference. And of course, I'm having to spend 171 to buy the drug, hoping to make something above 171 so that I can make some profit. But yet I get paid 151 or whatever I told you, 121. And so the point is that we operate in a negative. Didn't think we'd ever would operate in a negative. You think the worst it could get is just zero. But no, when you deal with PBMs, your profit margins are in the black. I'm not black, but in the negative. And
I want to come back to that cost in just a second, because I think that's an important thing we need to flesh out a little bit, because it really, I think there's ways that they try to.
Sorry, hang on a second.
Okay. Looks like you're a busy man this morning, but I think the PBMs are after you. But I wanted to give a little bit background history here and try to figure out how we got where we are and why.
There we are. Okay.
Why this cost issue that you described, you described it as theft. And obviously you have firsthand experience with that, and we need to explain that to the listeners. But, it seems to me that what I could find in my research, there are 3 PBMs. There's CVS Caremark, there's Express Scripts, and OptumRx. At least that's what I could find. Interestingly enough, they emerged, what I saw through research, in the 1960s. And they definitely emerged as an intermediary to attempt to help the process a prescription drug claim for insurance companies. Seems to me that, that's just them trying to advocate from their responsibility. But anyways, they were trying to offload some work there. And it looks like about 80% of those 3 PBMs, they control 80% of the entire PBM market. So it's almost a monopoly-esque, you might say.
Oh,
and when you
it's beyond monopoly.
When you extrapolate across that, it affects the administration of drug benefits for over 270 million Americans. So, I mean, it is impacting the entirety of the country as a whole, and clearly it is impacting for you. Now, initially you said, you kind of implied this, but they were there to manage claims and to reduce administrative burdens. I find that really interesting, to reduce administrative burden for the insurers.
Well, as an example, I would simply say that if I was to condense the story down into something simple, if you go back into the 80s, and this is when I kind of remember my father being a pharmacist and having to sign contracts on a fairly regular basis. The packet would come in, it would be from Blue Cross or United or whoever, and you would fill out the form and you'd agree to the terms and send it back in, and everybody was happy. But if you think about it, Blue Cross had to have dedicated an entire, wing or office or whatever to dealing one-on-one with thousands of pharmacies across the country. And that was a huge burden. So oddly enough, the irony is that a pharmacist invented this, if my story is correct, invented something called PCS, which is prescription card services. And he says, hey, I'm going to step in here and we'll do all that contracting for you. You pay me a fee, and then he'll do the contract. And he contacted us and then did the work. And then he was making money for handling money for them. But he also started keeping the spread between, like I said, the example of 300 and 121. That's what they call the spread. And they keep that. And they don't even lift a finger. It's automatic. As soon as it transmits through, they just suck it away, and your profit disappears and goes into nowhere.
Well, it's not just that, but it's the cost to the patient. So let's look at the cost here, the cost to the pharmacy, but the cost to the patient, just in dollars. So let's look at that first. So for you, the cost to the pharmacy, have you seen the reimbursements over the course of PBM management? Have you seen your reimbursements drop?
Yeah, drop. Yeah,
And so what have you seen PBMs? Don't they call that? Do they call that a rebate? What do they call that? Or they just is it a
Well,
charge?
it gets their huge advantage is it's extremely complicated, and we've been trying for 20 years to explain it to the politicians
Because
as
you've
to
been
what's
fighting
happening.
this. You've been fighting this on the state level.
Oh, yeah, this is not a new conversation. It's new in the sense that Trump's come out and said, "Hey, let's do something about it." And we're all quite excited, to see it. I was actually in a meeting a couple of months ago at the Capitol in Tennessee, where I was invited by the representative with three other pharmacists to explain our position, just like I'm doing here with the director of the Department of Insurance and Commerce. They are the ones that control the PBMs in the state of Tennessee. Each state's different how they do it. And very interesting conversation. But of course, they're tasked with investigating any wrongdoings by PBMs. And I asked him, I said, well, how many investigations do you have ongoing at the moment? And he had something like 5. And I'm like, 5? What's interesting about this is we handle these things electronically, instantaneously. You fill a prescription, you're getting one from me, I'm typing it in, I hit the button, bang, I get paid, I can see it. It's quite fast. But if the money comes back and it's, say, negative, right? I paid $10 for it and now you're paying me 8, then I go, I can't fill that. But by contract, I can't say, no, I'm not going to fill that. And so I either take the loss or I don't have the medicine or whatever the case is. And then I have to file an appeal with the PBM and say, hey, you didn't pay me enough money. And then they'll look at it and it takes another, 3 working days to get an answer. It may get an answer, maybe not. Ironically, if I don't get an answer and I submit again another appeal, again, just remember, this is all labor on our part. We're having to take
Which is money.
lots and
Which
lots
is
of time
money.
to do this because we're just trying to make profit, and we're talking about being paid a negative to start with, right? And so you're looking at it going, okay, I should have at least 10, but I need 10 plus as a profit. So it would be nice to have, say, $12 instead of 10, even though you're paying me 8 and it costs me 10. And so you have to file appeal. Well, then 14 days later, if they deny you and then you reassign that appeal to, there's a law firm in another state that you can send it to. If they determine that you're right and the PBM is wrong, which is usually always the case, then you get your money, you get your $1 or $2, which is not even worth fighting for because it's taken so long at that point. But the law firm gets paid $100 for their trouble.
And you lost 2.
Yeah. Well, no, I finally gained my 2 after, hours of it. So this is the insanity that's taken us. So we're trying to explain that to our representatives, trying to explain it to the Department of Insurance and Commerce, saying, the punishments that you have laid out for these guys is chump change. It's pennies on the dollar compared to this. You smack a PBM on the hand and say you can't treat people this way. Well, you need to make it hurt. I mean, it needs to be in the millions or even higher because they make so much money off of this and they don't even lift a finger. It's absolutely totally innocent. We even told them, and I'll go one step further. The sorry,
It's okay.
technical difficulties here. Now what I was going to say. Oh yes,
You said one step further.
yeah. I said one step further. I said to them, you guys really need to make a decision. Do you want PBMs in the state of Tennessee, or do you want pharmacies in the state of Tennessee? Because we're dropping like flies.
Great point, because that's where patients are going to say, but what's the impact for me? They're going to go, hey, I love Joe Nowell. I love the fresh pharmacy. I love what I can get there when I go to his pharmacy and get that just personal, individualized pharmacy care. But what is the impact directly to that patient, that consumer that comes in the door? Number one, there's a monetary loss, right? Because if the pharmacy is being paid a negative or break-even point, but most cases a negative, but yet the money going to the PBMs is going up and up and up. Basically, when you look at the cost,
Sorry.
when you look at the cost, when you look at the cost of medicines, when you look at the cost of medicines pre-1990, the increase annually was about 2 to 5%. That was
one more time. What?
So, and I was looking through the numbers. I was trying to get an impact on what the PBMs, as they kind of really got a foothold in the 1990s. They started in the 1960s, but they really got a foothold in the 1990s. But this price increase in meds, I think the way you can tease out the cost to the consumer, the patient here, is that the price increase pre-1990s of medications to the general public was 2 to 5% annually, roughly. Okay. But then if you look post-1990s, there was an annual increase of 10 to 15%. Now, that was average. When you looked at the 2000s with the biologics, the annual increase really started to exceed 20%. And then in the 2020s, obviously, particularly from 2017 to 2022, we saw that rise to 31.6%, 31.6%. Now, that was compared to inflation at the time of 17. And we all know the funny numbers that they play with inflation, but 31.6%. So if you compare pre-PBMs, annual rise 2 to 5%, and then what you're looking at since that time is 10 to 15%, there's no other way to say that what we're dealing with is the middleman is costing the patients more money because their medicines cost more money. Is that fair?
It's absolutely, it is the reason the money is through the roof. Let me give you a more accurate example. And this is part of what we told the politicians in Tennessee the other day. And this is what I would tell Trump, and this is what I would tell his czar, whoever he picks, is simply this. The manufacturers create a rebate. And so, when you buy those toys in toy stores, since it's Christmas time, and they're pre-printed and it says suggested retail price $19.99, but yet there's a red sticker on it that says $5.99. And that's how we buy drugs. We buy drugs that might cost $10, but the manufacturer's already slapped a what they call an AWP, or an average wholesale price, of like $1,500. They just randomly make this number up. We never pay $1,500 for it. Well, just as an example, if we can buy it at 10, but that's a number that's used to bill the insurance. And because the insurance will take that number and chop it down to certain percentages and then give dispensing fees and all that kind of crap.
For which
But
they get for which the PBM gets their take.
well, yes, but see, this is why everything is rising, because if you take something simple like diazepam that's been around for a long time, it's generic. You can buy it pretty cheap. They made it. And like I used to buy a bottle of temazepam, a different one. I used to, I used to buy like a bottle for $20, and then one day it was 800, and it's like, well, they can make it and sell it at 10 cents, or they can make it and sell it for $10, and so they know that because the consumer has a copay, and the copay is $10 for something that costs 10 cents, or it's $10 for something that costs $1,000. The consumer never sees it, and when that happens, the manufacturer goes, aha, I can make money because the patient never sees it. And what they're doing is they're rerouting it through the insurance. And then the patients end up paying more for insurance, more for medications.
And
And
more for
so
copay.
I'm having to pay a lot more for that medicine. And if the PBMs will have contracts, they'll have formularies. And they'll say, okay, well, this is only the drugs I have on this formula. That's all we're going to pay for. And for many years, it was just generics, so cheap, cheap, cheap. And then the brand names would never be on there because they're too expensive. And then one day the brand guys got smart and they said, hey, Mr. Formulary guy, what if we slide you some of the manufacturer rebate? And they're like, oh, welcome to the formulary. And all of a sudden, 25% of the cost of the medication gets rerouted into their pocket, and all of a sudden they're on the formulary.
That being the PBM.
Yeah. And all of a sudden, something that costs $20 is now $800. Why? Because they need to share that money to get on the formulary to move their market share. So and this is what we told the politicians the other day, you either get rid of PBMs, easy solution, I would love that, or you lose pharmacies.
Okay.
Or
Go ahead.
it's just like a war. You have to defeat the enemy. If you can't get rid of the enemy, at least quit giving them ammunition. And the ammunition for a PBM is the manufacturer rebate. So you make manufacturer rebates illegal, and then there's no incentive for them. There's no money they can make at that point.
From a consumer or a purchasing person, because at the end of the day, when I leave my clinic, my office, I am a patient, right? And so when I go to a pharmacy, I have to incur those costs. But when I think of rebate, I think, well, that rebate's coming to me because I'm the one that is buying this drug for my family. But in fact, the rebate goes to the middleman who is actually driving up the cost and then taking the rebate, instead of that rebate going to the patient, maybe, or even the pharmacy, because they incurred the cost in purchasing, it's actually going to the middleman, the PBM. So in essence, it's driving everybody's premium up, everybody's copay up, every cost of drug up. So it's not just one area where the cost is going up. It's going up at multiple areas, and it's reducing your revenue. And so I want to get into this. So it's clearly number one, a financial cost to the consumer, to the patient. Why? Because you have the insurance, you have the pharmacy, and you had somebody come in between. If you want to get it in a different picture, you have the voter, you have government, and you have somebody get in between. And when that happens, you disconnect the person that votes for the power and the power. And when you disconnect that, now the power has no recourse to be turned against by the voter. Here, the pharmacy is losing its capacity to turn against or fight against these restrictions and these monetary losses, if you will, because of this middleman. So they're acting kind of as a shield. But you said you're going to lose pharmacies. So the second cost
We're
is,
already losing them.
The independent nature of America's independent businesses. I mean, our country was built on this, and
true.
Where are the independent pharmacies, Joe? Where are they?
Well, think about it. We're just talking about independent pharmacies, but as an example, look at what Walgreens just said. Well, we're going to shut down like 1,200 stores the other day, and CVS is shutting down like 700. You can blame it on Biden's economy, but you can certainly blame it on the PBM activity. And then the CEO, if I got this correctly, the new person in charge of CVS came out and says, we don't really care about the CVS stores because we make so much money because we own Caremark. CVS spent
A PBM.
$9 billion cash buying Caremark years and years ago. And I think within a very short period of time, they make like a $23 billion profit. And they make more money owning the PBM because they're getting money for nothing and their chicks for free. I mean, it's insane. Now,
I was looking up in 2022.
shout out to Dire Straits, right?
There you go, man.
But anyway, I wanted to say that, for instance, you're a doc, I'm a pharmacist. If you write a prescription and I say, hey, every time you send a prescription to me, I'll give you $100. Well, we both go to jail because that's incentivizing, and we're not allowed to do that. You have to send it to me. There's no transaction between us. It's illegal for pharmacies and doctors to collude this way. However, it's perfectly legal for a manufacturer to siphon money to a PBM to get on their formulary, and that's okay. But if it's illegal for me and you to do this, how come it's not illegal for them to do the same thing?
And they're directly profiting from it. So
absolutely.
I was looking at some of the profits here, or the revenues. In 2022, CVS Caremark generated a revenue of $169.2 billion. Express Scripts in 2017 reported $100.065 billion in annual revenue. And then OptumRx in 2022 generated a revenue of $99.8 billion. These are billion with a B as in boy. We're talking big, big profits for this process and major, major losses. So, getting back to the pharmacy, we're losing not only the, every other corner pharmacy, the kind of doc in the box pharmacy, but we're also using that we're losing that independent pharmacy. So basically now what we're going to have is a lower choice. So the number of pharmacies patients have to go to is going to go down, right?
Yeah. Let me show you this. I don't know if you can see. Does this read backwards?
No, it reads fine.
Yeah, okay, because to me it looks backwards. Anyway, if you look here closely, this shows this is an article that was written about the Arkansas pharmacies and CVS. Now, CVS, who owns their own PBM, and this same medicine. Can you see that?
Yeah, I see it. I see the Arkansas pharmacy received $28.27 for a prescription of aripiprazole, 20 milligrams, 30 tablets. But the CVS pharmacy received for the same prescription, that's what I take, $512.83. So one pharmacy that is not attached to a PBM, $28.27, and the other over $500 that does have a PBM.
These are the kinds of problems we're running into. And this is what's causing healthcare. Now, I'm concerned. I like Kennedy, and I'm hoping to see some great things. But I'm concerned because I told you about Daniel Best, and you hadn't heard of Daniel Best. But back in the first term, Trump picked him, and he had some experience working for, I think it was CVS. He worked for a couple of big pharmas, and then he worked for CMS, or Centers for Medicare, I think it was. So he had government experience and he had manufacturing experience. And so he picked him to help reduce the cost of medications. This man was found outside his garage at 5 o'clock in the morning, taken to the hospital, pronounced dead. And it was ruled a suicide. However,
suicide by how?
Blunt force trauma. So I don't know anybody that wants to end everything by just beating themselves in the head. I don't know. There's 1,000 other ways to do it effectively, but I can't imagine somebody doing that. It's just one of those stories where I'm concerned that anybody gets put in the position of correcting this.
because there's a lot of money involved. We're
There's
talking basically
a
hundreds
lot
of
of money
billions,
involved.
hundreds.
What?
And if you look at the three PBMs, which control 80% of the market, you're looking at over $300 billion.
Yeah.
I mean, so you're not talking about pocket change. So it's costing the patient more money, drastically more money. It's it's basically eliminating pharmacies. I mean, how many independent pharmacies have you seen go by the wayside in your professional career?
A lot. I don't even know. I know one fellow was keeping track of it, and he finally gave up. Um, but I did find an article several days ago, and it was about, I think it was Kentucky pharmacies, and they had tracked it, and Ohio pharmacies had been tracking them, and they were losing a lot. And I forget the numbers off the top of my head, but it's a significant problem, and old ones, like the oldest pharmacy in Tennessee, which is outside Gallatin or in Gallatin, outside Nashville. It had to shut its doors several years ago because it couldn't pay the bills. And you can't pay the bills when the PBMs take all the profits.
So
And,
then,
you know,
the patient has less access to get to drugs, which when you have less pharmacies, you have
that's
less
right.
access. We know that further drives up the cost
Hmm.
because there's less competition. The way, I mean, I'm a doctor. And my knowledge and learning in business has come from the hard way. We doctors think that, well, we're a doctor, so we should know how to run business. How hard can it be? Come on now. Yeah,
That's true of
right. That
all of
never,
us.
yeah, that never works out really well. But some very simple principles is if you have less access, less choice, you have more cost. And when you increase competition, that means increase access and increase choices, that creates pressure to lower the price because then you're having to compete against people. And price is one way that consumers can really compete with these companies. The companies go, wow, I've lost a customer here. I'm going to lower the price here instead of $10 to $9, whereas they're at 11. And then they see that and they go, wow, I'm going to drop that to 8. What they're doing is they're further driving up the cost by driving out pharmacies. But I want to touch on this for you because you mentioned formulary a couple times, because I think that ties in here as well. What's a formulary and why is that relevant to a patient?
Well, it's just a list of drugs that a company will pay for or will not pay for. If it's not on the formulary, they won't pay for it. And they have formulary committees. I remember this when I was going through school. They put us on those in the hospitals, and you just review medicines on a regular basis to see how much they are, how effective they are. Compare it, like, which, if you've got 10, benzos to pick from, what do you want? Do you want one that has long acting, short acting? Do you need to pay for, which one's the cheapest? Which one's the most expensive? Well, everybody's trying to save money, so they're avoiding that. And so it was a way to trim it down. Instead of paying for everything under the sun, they'd say, okay, I only pay for this particular drug, this NDC. That the NDC is the number we use to identify it, and we'll pay for that. Um, and then we started seeing the brands come in, and we're like, hold a second, why would in Tennessee, why would TennCare pay for a brand and not a generic? Well, there's only one reason, because they're getting a rebate. And we know this is occurring because CMS did not know how to do this, and they contacted Humana and said, hey, we understand you're making a lot of money off rebates. How do you do that? And so Humana and CMS got together with Medicare, and they taught them how to make money off of rebates. And so the government is now doing this. If Trump's going
Meaning
to
it's
look
being
and
driven
get
by the
into this,
PBM. And now the
look
PBM is
look
driving
close,
profit for the government.
look closely, because the government's doing it too, and it's just it's
So
so
get this.
complicated. We
Oh,
just shake our head and go, man,
I
gosh.
don't think I don't think it's actually quite complicated. I think it's actually right here in the open. And
Well,
that's
yeah,
and that's kind of the scary part. So the government taxes us, right? Everywhere we turn, they tax us. They take our money. And then what they're doing here is they see that the PBMs are driving profits for health insurance through the rebates, which should be money that's going to the patient to pay for their medicines and to lower their costs. But in turn, it's driving up the profits of PBMs, and they're turning around and basically the insurance companies are profiting from that as well. But then the government, that is Medicare and Medicaid services, goes, wow, look at that profit. So taxes aren't enough. So we're going to go to the PBMs and the health insurance companies, and we're going to learn how they're further profiting from this money. And so now, basically, in essence, for them, it's another tax to gain revenue.
Yeah, and we're talking about just the simple stuff. And we're not talking about remunerations. We're not talking about clawbacks where they not only do they not get enough from the patient in the copay, they'll say, "Oh, you owe me $10," but then it's like, "We really want more." And so then they reach, and I get the $10 copay, and then they reach into my pocket and take $6 out of that $10 copay for themselves, instead of saying, "Patient, hey, just pay us an extra $6." They take the money from the patient, but not tell the patient because they take it from us, and that's called a clawback. These It gets so complicated and so corrupt. Um, it's
But this is what's really interesting, because the PBMs, which are the middleman, they're dictating what drugs patients have access to
Absolutely.
and the cost of those drugs as they drive up the cost of those medications for that patient as they drive down the access, because the pharmacies can't afford to stay in business and they go out of business.
That's right. And then you end up with, like, you're going to end up with a handful of people, a handful of pharmacies, like 3. And you think that you're going to have any
It's going to be mail order. It's going to be mail
competitive,
order. It's going to be Google
right?
Pharmacy or Amazon
Yeah,
Pharmacy or
you'll end
something.
up with a handful that can dictate price because there's no competition. It's it's a
But here's what,
it's a pattern that needs to stop. But hey,
and this is what's really interesting, Joe, because you would think the people that need to determine what drugs are beneficial and what needs to be available on the market for patients, and then let the market control the cost, is a doctor, a pharmacy, and a patient.
you
You would
think?
think, I mean, I know I'm being archaic and thinking back
Yeah,
to things of the past where,
yeah.
man, who writes the prescription? A doctor. Who fills the
Well,
prescription?
it's the
A
chief
pharmacy.
complaint. It's the
And who
chief
receives?
complaint I hear I hear from the doctors all the time is, where did they get their medical degree? I think it's what you guys always complain about, because you want to give drug X, and then the insurance says, no, 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 you need to try drug, X, Y, or Z before you try that one. You know, it's they'll
But see what they're doing though, they're driving a drug, they're forcing the doctors to write a prescription for a drug that they may or may not want to prescribe, but that drives profits for that PBM.
sure,
So they're
absolutely.
basically creating the playing field, the market, if you will. They're eliminating competition and they're driving their own profits.
And the health of the patient is not
Oh, it's
at,
irrelevant.
at
Irrelevant.
is irrelevant is a great way. Is It is not on the top of the list. That's for
The
sure.
patient in this model here, Joe, the patient's the commodity to buy and sell.
That's
That's it.
right.
That is it.
That's the at the end of the day, that's the problem.
So
I'm gonna have to cut it short.
yeah, real quick, if we
But
could tie it real quick. Do you think two things? Does this influence how doctors prescribe? I've already touched on that. And do you think this is a reason why these repurposed medications, many of them, are so hard to get access to?
Well, it's exactly why it's hard to get access to, because if something is non-patentable, then there's no profit to be made by the drug companies. And so they'll do anything they can, creating false information, or what we call disinformation, to make it sound like, oh, that stuff doesn't work. It's old. Don't think about it. Use my new fangled medicine that we just patented the other day. And then they're advertising there. And but these things are work. I mean, iodine works. Fenbendazole works. Oh, well, mebendazole.
That is
The
all, yeah. Ivermectin.
ivermectin, yeah, there's a whole bunch that are off patent that were perfectly fine and work great, and they still do. And the last thing you want as a big pharma, is an affordable, accessible, effective medication. And that's, at the end of the day, um, that's why there's a drive to get these things. And because they're looking at it and saying, well, we're going to give you a drug that's going to create a whole series of side effects, that's going to cost you a $250 copay, and at the end of the day you've actually paid like $30,000 for the medication that doesn't work. Like in a case like somebody has MS or Parkinson's or some weird where you're going to give them some biologic. And it's like, if you looked at the side effects of these things, if you looked at the overall effectiveness of these things compared to just say eating healthy, but
Yeah, but
I
that's
don't
true.
know. I'm there's
And that's
so much to touch on, and I don't think I'm giving it a
You are. But here, I think here's the take home so you can go enjoy the holidays with your family is that number one, it drives up the cost for the patient, the PBMs.
yep, it sure does.
And it drives up the cost of the drugs. It drives up the cost for the patients. It drives up the cost for the premiums, the copays, which drives up the cost for the patients.
It
Number two,
delays
go ahead.
it delays access to medication. They create
Delayed. Yeah, we
prior
didn't talk about that.
authorizations that make people wait for the medications. Um, and then when they're causing a step therapy, causing you to use drugs that you don't need to use, for weeks and weeks and weeks before you get to the drug you really want to use,
It impacts
because
the
they
health.
want to save money. Yeah,
Yeah, it impacts the health. It's all a profit-driven model for the PBMs. And again, the patient is simply the commodity. It drives down the number of
that's right.
pharmacies. It reduces access. You talked about the stepwise process. It's impacting negatively the health of the individual because the doctor is not being allowed to prescribe the medication he wants. Essentially, the doctor's ability to autonomously prescribe a medication for a patient is overridden by a PBM and their policies and their regulations that they basically wrote out of thin air that are basically acting as law within the confines of medicine. And what this is doing is it's negatively impacting the health of the patient and it's overriding the doctor's authority as a physician to write a prescription. But then it's actually manipulating the practicing pattern and prescription pattern of doctors, and it's restricting overall the number of medicines that are available because of formularies. So it is, in its essence, PBMs have created a marketplace where everybody loses except them.
Sure.
And so hopefully President-elect Donald J. Trump will get rid of them. Hopefully incoming Health and Human Services Director, um, RFK, and then Dr. Oz with Medicare and Medicaid services. Hopefully, they're going to make some changes that will, guess what? Put the power back in the hands of the patient, restore the doctor-patient relationship. That'll restore the pharmacy relationship as well. And it's just going
Be
back to
nice.
simple things. Give the power back to where it belongs. That's the people. Let doctors prescribe and take care of patients. Let patients receive that care. Let pharmacies step in and fill that care. It's just like going to get on a plane this holiday season, and the bus driver goes, "Hey, I drive a bus, so I'm gonna fly this plane today." Yeah, that ain't gonna go well. That ain't gonna go well. Or traffic controllers saying, "You know what? I'm gonna step in here and fly this plane, and I'm gonna actually write how you fly this plane. So you don't, as a pilot, fly it how you know to fly it. I'm a air traffic controller because I know something about airplanes, but I'm going to tell you how to fly the plane. I'm going to write your emergency protocols. I'm going to write everything about how you fly a plane, but you don't fly a plane. You're right, but I watch planes fly on my screen every day. And so people go, well, that makes sense. Yeah, you would never want to do that. But here, I think it happened under the nose and nobody knew it until everything cost so much. And so, Joe, thanks for coming on. I know you got to run. Just a little bit of a deep dive. I thought this was relevant because when we're talking about repurposed medications and people go, why can't I get niclosamide? Why can't I get mebendazole? Why are they so expensive? Guess what? It's because they're not on a formulary and they're off patent and there's no profit that can be made by PBMs. So guess what? You can't get access it because a pharmacy can't get access to it because a PBM has said, yeah, we're not going to put it on the formulary because we can't make enough profit from it. That's the system we live in, but we can make a change. That's the exciting thing. We can make a change. You as the patients listening to this Off-ScriptRX podcast, if you want repurposed medications, you need to be the force vector of change. The way you do this is you talk to your local representatives, you talk to your state representatives, state senators. We have to change this at the power of the people. They are the force vector of change. We can do this. We can do this. If we have repurposed medications that are highly effective, we must have access to them. So thanks for joining this Off-ScriptRX podcast. Go over to off-scriptrx.com where you can see our blog posts, all of our previous podcasts and videos. You can check us on YouTube, Rumble, all over the place, and of course on any social media you want to find. We need your help. Please share and grow this movement of repurposed therapies, not just medications, but also therapies and supplements. Give us a 5-star review. We would greatly appreciate. Engage, discover, empower yourself, force multiply this movement, and please share, like, and subscribe. Until next time, I'm Dr. Nathan Goodyear of the the off-scriptrx.com podcast. And this is with Joe Nowell. We are two doctors talking repurposed drugs and doing a little repurposed drugs.
Thanks for having me.
Your health deserves more than a one-size-fits-all approach. Subscribe now and share this episode to help others break away from outdated treatments. Visit Off-ScriptRX.com to see how repurposed medications can fit into your personal cancer care strategy. Don't settle. Take action and join the movement to rewrite the future of medicine. Rethink repurposing medications. Rethink reality.